I am delighted to introduce our first presenter. I will spotlight Dr. Erin Lasker. Dr. Erin Lasker graduated magna cum laude from Brown University with a degree in neuroscience. He completed his medical education at Tufts University School of Medicine and completed his neurology residency at Beth Israel Deaconess Medical Center in the Harvard Neurology Program, where he served as chief resident. Dr. Lasker went on to complete a joint fellowship in movement disorders and cognitive neurology at Beth Israel Deaconess Medical Center in Boston. Following graduation, he worked as the division director of the Movement Disorder Center at St. Luke's University in Allentown, Pennsylvania. This is when he conducted research on mindfulness meditation and Parkinson's disease. Dr. Lasker was recruited to the University of Pennsylvania this year in 2021, where he now serves as the director of the Huntington's Disease Center of Excellence and is a palliative care champion in the Parkinson's Disease and Movement Disorders Center. He is also a member of the International Neuro-Palliative Care Society, where he sits on a patient education committee. So we are honored to have Dr. Erin Lasker presenting today on palliative care. Thank you so much.
Okay, let me just get my slides up. All right. Great. Thank you guys so much for having me. This is a real honor to get to talk to this group. And thank you for giving me the opportunity to talk about this really important topic of palliative care in Parkinson's disease. Palliative care has a really long history in medicine, but only more recently has been applied to neurologic disease, in particular Parkinson's disease. And a lot of the effort around this has come from the Parkinson's Foundation and incorporating palliative care into centers of excellence. So in the Parkinson's disease world, I think you're going to be hearing more and more about palliative care over time. So I'm happy to have the opportunity to explain a little bit about what it is. So just a brief outline. It's pretty simple. I'll talk about palliative care in general. A little bit about advanced care planning, so making sure all of your paperwork is up to date. Very briefly touch on hospice, which is very different and is separate from palliative care, but is an important thing to talk about. And then the last half of the talk will be about Parkinson's wellness, which will be fun. Okay, so what is palliative care? Palliative care has a long history. Originally started in the context of cancer care, but has really spread throughout all of medicine. The term itself, to palliate, originally comes from a Latin word that means to cloak. So it's sort of like to wrap a warm blanket around someone. So this was sort of the best image I could find to describe that. So it doesn't matter exactly why this adorable dog is, feeling cold or unwell, but you can make him feel better by wrapping him in a warm blanket. So that's sort of what palliative care is. It's about lessening suffering and making things less unpleasant without necessarily removing the underlying cause, sort of regardless of the underlying cause. There are a lot of misconceptions about palliative care, and the more people I talk to about this, the more misconceptions I learn about. So the first one is that palliative care is not the same thing as hospice. So we'll talk about hospice a little later. They're separate. They're often services that are offered by the same group. So the terms come up together a lot, but they're very distinct. Palliative care is definitely not euthanasia or death squads, which was a popular term some time ago. Palliative care is not only for the imminently dying, which we'll discuss a lot. Palliative care can be really useful sort of throughout the disease course of serious illnesses like Parkinson's disease. It's not only for cancer, even though that's where it got its origin in medicine historically. And I came upon this one recently. It's definitely not throwing in the towel. I would argue actually it's the exact opposite of throwing in the towel. I really like this definition a lot. I think this is the best one I've come upon. The palliative care is really a framework of medicine, as a way of thinking about medicine and care that's all about living as well as you can for as long as you can. So in the context of Parkinson's disease, I think this is hoping for a cure for tomorrow while making the most out of today. And palliative care really takes a very broad view of care and asks the question, are there more ways that we can improve someone's quality of life today? Instead of just focusing on a few narrow things like tremor control, which is super important in palliative care, what else can we do to improve someone's quality of life today? So this is saying it again a little bit differently. It's an approach to care that really focuses on quality of life, reducing suffering of people with serious illness. And palliative care uses a few different tools to try to achieve this, including intensive management of complex symptoms, psychosocial and spiritual support, so supporting people's mental health, addressing their social situations, their spiritual lives. And it also affirms and supports life while addressing death as a normal and expected process. So that's sort of part of palliative care as well. Now, palliative care, as I said before, is not just for people who are imminently dying. Actually, is really appropriate and can be very, very helpful throughout the course of someone's disease. This is from a paper about neuropalliative care in general, not necessarily Parkinson's disease, but a lot of people feel that palliative care needs are probably actually one of their highest points right at the time of diagnosis. So thinking through sort of what does this diagnosis mean to you as a person? What are the existential impacts on you as a person when you get this diagnosis? Caregiver support is really a pillar of palliative care. And so at the time of diagnosis and throughout different stages of the disease, making sure to support people's caregivers, care partners is extremely important. And then along the way, there are sort of points in the course where maybe things change or shift in the disease or your life, where it's important times to sort of stop and think about what your goals and values are in your care, so that you can take a really active role in shaping your care and working with your care team to shape the care in the way that you want it to be, to shift the care towards promoting your personal values, what's important to you. One really important thing to recognize about palliative care and this sort of attitude towards care is that focusing on quality of life does not sacrifice quantity of life. So a really quality of life focused, quality of life oriented care structure does not shorten life or life expectancy. And this has been studied pretty rigorously in different settings. This particular study was a very well done study in the setting of an aggressive form of lung cancer called non-small cell lung cancer. So not in people with Parkinson's disease, but I think the principle is will likely be proven true kind of throughout medicine. But basically here, this is a plot of the number of people who have survived with this very aggressive form of cancer. And this red line represents people who had early palliative care, so sort of this palliative care approach incorporated into their care right away. And the blue line are individuals who got standard of care, but no palliative care. And actually, these lines are quite separated because the individuals who got the early palliative care actually survived a lot longer than the people who got standard care. So not only did it not hasten death in any way, it didn't worsen prognosis, it actually dramatically improved prognosis. And I have a sense we'll probably find the same thing to be true in other neurologic diseases like Parkinson's disease. So there are some specific areas in Parkinson's disease care where palliative care can be really helpful. These are some unmet needs in Parkinson's, areas that we don't tend to do particularly, we're not particularly good at in the conventional models of Parkinson's disease care. One really big one that I kind of touched on very briefly earlier is the impact of the words, "you have Parkinson's disease." I think we don't always support people enough right after the time of diagnosis. And this is a time that more supportive care, sort of a broader concept of care, can be really useful. The other is the underrecognized and often undertreated non-motor symptoms of Parkinson's disease. And these can be particularly relevant later in the disease course. So the motor symptoms we're all quite aware of, like slowness, stiffness, tremor, or walking troubles. But some of the non-motor symptoms include depression, anxiety, sleeping troubles, thinking troubles, dizziness, those sorts of things. And so addressing those non-motor symptoms can be really, really valuable at improving people's quality of life. Another is the impact on roles and identity and relationships after the diagnosis of Parkinson's and as the disease progresses. I have a very vivid memory of a conversation with a patient of mine where, the more we sort of drilled into the impacts of his Parkinson's symptoms on him, one of the most bothersome pieces for him was that he was no longer able to change light bulbs safely. And that had always been sort of his job in the household. And now it was something that he needed help with. And adjusting to that reality was really, really challenging for him. But getting to sort of talk through it and address it together was really helpful. Another area of unmet need is the spiritual and existential challenges of having Parkinson's disease. For a lot of people, sort of incorporating the fact of this diagnosis into your lives, into your sort of spiritual, existential framework can be challenging, and being supported in that challenge can be very helpful at relieving suffering. Caregiver support, I've touched on already and will again later, is fundamentally important in the care of Parkinson's patients, is taking care of their support team as well, not just the patient. And then finally is the fact of increased mortality in Parkinson's disease. And where for the most part, Parkinson's disease is something you die with, not something you die from. It does have an impact on mortality and longevity, and that's something that we need to talk about honestly and prepare for. A couple of facts below that show that we're probably not doing a great job of preparing for this is that very few people with Parkinson's utilize hospice resources at the end of their life, which is a really wonderful program, just 4% of patients. And a high percentage of patients, 50% or more, die in the hospital. And if you ask most people, and if you ask yourself if you would rather die at home or in a hospital, the vast majority of people would prefer to die at home. So the fact that most people are dying in the hospital means we're not addressing that core value for a lot of patients. So why is it that we have to talk about death anyway in the context of palliative care? This slide is a little bit outdated, but I think the trend holds. Death is one of the few guarantees in life, and it's something that makes sense to prepare for. And that's where the concept of advanced care planning comes in, which is planning for the eventuality of death. And advanced care planning is something that's super important for a handful of reasons. So I'll spend the next handful of slides talking about it. But one of the really big ones is that it really takes the pressure off of patients' families to make these decisions for them when the time comes. So by being really clear and having all of your paperwork filled out and having these often difficult, certainly not fun conversations with your family, it takes the pressure off of them to make these decisions for the patient at the end of their life. So we'll talk about it a little bit now. The first step, a really major step in this process, is selecting someone as your medical decision maker. So this takes a variety of different forms, have different terms, the most common of which would be a healthcare proxy or a healthcare power of attorney. And this is basically answering the question of if you couldn't make decisions for yourself anymore, who would you want to make decisions for you? One really important thing to note is that the power of attorney doesn't actually go into effect. Whoever you establish as your power of attorney does not have any power until you are no longer able to make decisions for yourself. So I actually saw a patient on Friday who told me that they had all of their power of attorney and living will paperwork filled out, but were hiding it from their kids just to make sure that that they didn't put it into effect too soon. So that is not something you have to worry about. No one can put this into effect until you are actually not able to make decisions for yourself. So after you've established someone as your healthcare proxy or medical decision maker, the next piece is to think about what your values are. And ideally, you would talk about them with your medical decision maker, your healthcare proxy, but you can at least write them down so that they're documented for later to have access, for your power of attorney to have access to. And this is the concept of advanced directives or a living will. It's really a way of stating your values around end of life. This can be both sort of broad concepts of values. So for example, it may be very important to you to be able to watch the Eagles game with your family. So being able to bond with your family over these specific activities may be something that's really fundamentally important to you. So that's something that you could write down. Also, there are certain specifics that should be listed in these advanced directives or in a living will. And those specific ones are whether or not you would want to receive CPR, which basically means if your heart were to stop working properly, it wasn't pumping blood properly, would you want to be allowed to pass away naturally at that point, or would you want CPR, chest compressions, and all to attempt to revive you? Similarly, would you want to be intubated, which basically means being put on a breathing machine if you're no longer able to breathe by yourself, and whether or not you would want artificial nutrition or hydration through tubes. The reason that these particular things are so important to have documented and discussed is because in America, we're in an opt-out system, which means that if someone is found down, if someone is unconscious or is found that their heart isn't beating properly, the default is that that person should receive CPR. So if EMS is called, the default is that you get chest compressions and put on a breathing machine. If you don't want that to be the case, if you would like to be allowed to pass away naturally if your heart were to stop working properly, you actually have to actively opt out. And so that's why filling this, having this stuff written down ahead of time is so important. All of this also allows people to take control over what's going to happen in the last days of their life. There's a lot that we don't have control over in life and in Parkinson's disease, but this is something that you can have an active role in and really take ownership over. So how do you actually do it? So if I've convinced you that these are important things to do, what should you do next? There are a few different resources to fill out advanced directives and power of attorney forms. At the University of Pennsylvania, we've designed a website that can be really useful. You do not have to be a patient at Penn. This is just a free website online, which is called ourcarewishes.org. And this is what the main page of the site looks like. So if you go onto the website, you can click on these different tabs and fill in your information and then print things out so that you can sign, distribute to your healthcare proxy or to your neurologist or primary care doctor. The most important one that we talked about before, kind of big first step, is the medical decision maker. So you can establish who your primary medical decision makers should be. And then if they're not available, you can choose sort of a secondary and tertiary decision maker. One big motivator for a lot of people in establishing a power of attorney is the fact that most people, can think of someone in their family that they would rather not make medical decisions for them. And in order to choose who would make the decisions for you and make sure other people don't have the power to make decisions for you, filling out this can be quite valuable. If this isn't available when needed, different states have different rules about how the decision-making process goes. So in Pennsylvania, there's a hierarchy starting with your spouse and then parents if they're available, and then children. But with each of those levels, whoever is available, the decision-making power is spread out evenly amongst the group. So if you have multiple children and the power or decision-making power is spread out between all of them, that can create a lot of stress and conflict in an already difficult time. So establishing individual decision makers can be a real gift to the family. And then there are these other sections about quality of life, sort of what's really important to you personally, such as being able to enjoy the football game with your family. What treatments would you like? So this is like the CPR, breathing machine sort of questions. And then goals is a little bit more sort of open-ended about what's important to you in your care. What should your care be focused on? Another really useful resource is this website called 5 Wishes. So if you click on this individual and family section, you can have one of these 5 Wishes documents sent to your house. It does cost money. It's about $5, but it's a legal document that's recognized in Pennsylvania. And so this allows you to establish who's going to be your healthcare decision maker. And then it runs through a series of other questions, 5 questions in total, about end of life wishes. You can have it signed and witnessed, and it becomes a legal document, which can be quite helpful and saves you a trip to the lawyers. One final piece of documentation, which is useful to know about, is called the POLST form, which is also a legal document. Unlike the 5 Wishes or our care wishes that are signed just by you and witnesses at home, a POLST form is signed with your physician or nurse practitioner. And it is also it's a Pennsylvania specific legal document. It's usually printed on pink paper and put like on the refrigerator, someplace very obvious. And is particularly useful for people who would not want CPR or to be placed on breathing machines for those reasons that we discussed before, because of the opt-out system. So if EMS was called to the home, this would be something that would be easy to access and very visible in those sort of emergency situations. So I'll just very briefly show you what this form looks like. This is the top half of the form and asks these questions we've reviewed, mostly surrounding CPR and the breathing machine. Some other questions that they ask are like the artificial nutrition and hydration that we discussed before, antibiotics, and then there's this section down below about patient goals and medical conditions. So you could sort of write a little bit more to guide your treatment team in terms of your personal wishes and values. Okay, so we've navigated through the paperwork section. Great, so one last piece on the advanced care planning side is just quickly to talk about hospice. As I said before, hospice and palliative care are 2 distinct services. They have some overlapping kind of common ground, mostly focusing on comfort care, reducing stress, complex symptom management, and this sort of broader scope of psychosocial and spiritual care. But while hospice is very different, it's also a very helpful service for those who need it. The main distinction between the two, the kind of absolute distinction, is that hospice is for people who are at the end of their life, specifically people who have been given a prognosis of 6 months or less. Hospice does utilize a large interdisciplinary team of professionals to help patients who are actively at the end of their lives. And this is a federally funded program, so all medical costs are covered by hospice. So this is a really great resource for patients and is a way to get a lot of healthcare costs covered. The other piece, another sort of misconception, is that hospice is a service, not a place. So hospice is a service that you can receive in your home, in a hospital, in a nursing home, in a rehab center, rehab setting. There are hospice houses, specific places where you can go to get hospice services, but hospice in general is a service that can be received in various places. Another useful thing to recognize is that you can fail hospice. So if after the 6 months is up, you no longer have a prognosis of 6 months or less, people can just come off of hospice. If you get to the end of those 6 months and you still have a prognosis of 6 months or less, you can just stay on hospice for extended periods of time. So it doesn't have to be for people who are really sort of imminently in the last days of their life. Really, it's in the last months or potentially even longer. So this is a somewhat intentionally busy slide. So these are all of the different services that are paid for by hospice. So it's this interdisciplinary team that we talked about, the medicines needed for symptom control, different equipment like wheelchairs or hospital beds for inside the home, therapies, certain hospice services will pay for therapies, others won't. That's one issue that sometimes comes up. Dietary counseling, sometimes short inpatient stays. A really useful one often is respite care. So as a way of addressing the potential of caregiver burnout. So respite care is time for a loved one or care partner to have time away for their own wellness. And then grief and loss counseling for the family after the loved one has passed for 13-month bereavement period. So one last slide of this section, some signposts along the way. So these are some signs that a patient with Parkinson's may be entering the end stages or the late stages, at least, of Parkinson's disease. Now, none of these on their own mean that, but they're just some signs that can come up that can make you think about palliative care and times when it's worth updating your wishes and talking to your care team. So these include really extensive weight loss, recurrent infections, or frequent hospitalization. So if you're finding you're going to the hospital more often, side effects of medicines are starting to outweigh their benefits, frequent falls, really significant swallowing troubles, and significant increase in daytime sleepiness. Great. So that's the end of this first section. So the next section is about Parkinson's wellness. So just like it's worth coming up with a specific plan for end-of-life care, it's also worth coming up with a specific plan for living well today. When I was living in Boston, I had a meditation teacher who was a Buddhist monk whose name was Larry Rosenberg, and he was probably in his late 70s at the time. A patient asked him, you grew up as a young Jewish man in Brooklyn, and now you're a Buddhist monk, and they wanted to talk about sort of his thoughts about death, and specifically asked what his thoughts were about life after death. And his response was that he was much more interested in life before death. So that's what this section is about. So this quote comes from a really excellent resource from the Davis Phinney Foundation that I'll quote a few times in this presentation, called Every Victory Counts, is a book that you can get from that group. And they have this really lovely quote that these are the cards you've been dealt. Play your cards and play to win. And this is really what palliative care is about to me, is getting the most out of the time that you have. So one really important piece for Parkinson's wellness is building your dream team, sort of having your full team of Parkinson's care put together. You, the patient, is a fundamental part of that team, of course, and taking care of yourself is a lot of what I'll be talking about over the next few slides. Your care partner, caretaker is a huge part of your team, friends and family, your primary care provider, your neurologist, rehab specialists like physical therapy, occupational therapy, and speech therapy, a mental health provider for some patients, your community as a whole, and if it's an important part of your life, a spiritual advisor. So one really important and probably the most obvious piece to wellness is to stay physically active. This is a really, really important way to take care of yourself. Patients with Parkinson's disease often feel better. They feel fewer symptoms when they're remaining active. And aerobic exercise, like cardio exercise, is the only thing that's ever been shown to potentially slow the progression of Parkinson's disease. So it's really valuable for Parkinson's disease. It's good for your overall health and your mental health. And it seems from the literature, the minimum of probably 30 minutes, 3 times a week of moderate intensity aerobic exercise, like stationary bicycle or brisk walking, stuff like that, seems to be the threshold where there's this real brain protection effect, and probably heart protection effect as well. Another really important aspect of wellness is diet. And we're learning more and more about the importance of this over time. And one particular diet has come out as being particularly valuable in different brain diseases and specifically in Parkinson's disease. And that's called the MIND diet. So this is a version of the Mediterranean style diet that was designed specifically to prevent neurodegenerative diseases. Initially, it was studied in Alzheimer's disease, and actually in one study from Rush that was very well designed, it reduced people's risk of getting Alzheimer's dementia by 53%, which is pretty amazing. And in more recent studies, it's been shown to reduce people's risk of getting Parkinson's disease, and some signal that it may actually slow the progression of the disease as well, though it's a little too early to know for sure. Another important aspect of Parkinson's care is remaining mentally active. This falls into the sort of use it or lose it category of medical advice. And this can come in really different forms. So any sort of mental activity that you enjoy engaging in is probably the best one for you. So it doesn't necessarily have to be sort of brain games, but reading the newspaper and arguing about politics with family or friends and things like that are great ways to stay mentally active, which keeps those faculties sharp. Another really important aspect of wellness is staying socially engaged. Sort of positive relationships with other people is really, really powerful. And I think as a culture, we've really learned the power of this over the course of the pandemic. Staying home by yourself is not good for you, it turns out. There was actually a study that was done quite a while ago in a nursing home that showed just how valuable connection can be, where in the nursing home, all of the residents were given a house plant. And for half of the residents, they were told, this house plant is for you to enjoy, we'll water it and take care of it. And for the other half, they said, here's a house plant, it's up to you whether the plant lives or dies. And they followed everyone over time. And actually the people who had to take care of their own houseplant, who were more engaged in that way, actually lived longer than the people who didn't. So even those simple forms of engagement can be really valuable, and for sure engaging socially with other people in your community is really fundamental. Another simple one, but really, really powerful one can be getting a good night's sleep. So I'm sure many of you have noticed that if you get a bad night's sleep, Parkinson's symptoms tend to be worse the next day. It also turns out there's more research that's been coming out recently that the abnormal proteins that tend to accumulate in brains that cause diseases like Parkinson's or Alzheimer's disease are actually cleared out at night while we're sleeping. So not only do people tend to feel better the next day after a good night's sleep, but sleeping actually has a fundamental role in the process of neurodegenerative diseases. Now, all of these things are super important for patients. They're also really important for care partners as well. And thinking about caregiver, care partner well-being is very, very important and vital to the care of patients with Parkinson's disease in general. These are a couple of guides, one from the Davis Phinney Foundation, written by Davis Phinney's wife, or sort of directed by it. And then from the Parkinson's Foundation, this guide for care partners. So these are really great resources. And why, what are some reasons why the wellness of caregivers is so important? I like this illustration you're all familiar with. I think demonstrates the point. If you don't have any energy to give, to care give, it's not going to be as impactful, of course. And put another way, can't pour from an empty cup. So some different benefits of self-care, particularly for care partners, is more energy, preventing burnout, emotional stability, and also, almost more importantly, is really engagement and finding meaning in caregiving. So I would recommend making a really specific plan, a really specific wellness plan. And one way to do this, there are a couple of different schema I'll talk about. But one way is to think through these 4 different categories of wellness and think of something really specific in each category and put it on your calendar. So come up with a very specific weekly plan for wellness and actually write it down. And you're way more likely to stick with it if you do that. So the 4 categories are something physical, which could be going for a walk or eating a healthy meal, something social or emotional, like volunteering, something mentally stimulating, like watching a lecture on Parkinson's disease or reading a book chapter, and something spiritual, which can be in a religious context, or could be something like going for a walk in the woods and appreciating nature. Another really important piece of all of this is mindset. So this is where the title of my talk comes from. So this is another quote from the Davis Phinney book, Every Victory Counts, that says, if you focus on Parkinson's, then you will be depressed, anxious, apathetic. But if you focus on what you can do to live well and be happy, that changes everything. So being able to adjust your mind, your mindset and your focus can be really powerful. One of the leaders in the field of neuropalliative care is Benzie Kluger, and his quote on this is focus on the cheese. And this is my daughter, just for representation, showing us what we're talking about here. So either you can focus on the holes, which are the limitations and the losses, or you can focus on the cheese. What can you still do well? Where can you find joy and meaning? And can you even find ways to grow through this illness? That's what it means to focus on the cheese and that sort of big picture palliative care. Another framework to think about wellness, in addition to the kind of physical, emotional, mental, and spiritual, is this concept of positive psychology. So this was born out of the psychology department at the University of Pennsylvania, starting back in the 70s. They have this really useful mnemonic that's called PERMA that I find really useful to think through all of this. The P in PERMA is positive emotion, so things that make you feel good, like joy and happiness. Interestingly, from their research, positive emotions, sort of the amount of time you spend experiencing positive emotions, is only about 30% modifiable. So no matter how much effort you put into having more positive emotions, you can only move the needle a little bit in that area. Engagement is the E, is another really important piece. This is what are those activities that you really get absorbed in, that you tend to lose track of time in or fall into that flow state? R is for positive relationships. We've already talked about that a couple of times. M is for meaning. What do you feel like you were put on earth here to do? What is it that brings you meaning and purpose, and focusing on that? And then A is accomplishments, which can be big things like accomplishing things off of your bucket list, or even small things. There's some research a concussion expert did that showed that even specifically snapping your fingers 50 times, achieving something small like that can give people a little rush, a little increase transiently in their well-being. So even finding these little victories, little things that you've accomplished and celebrating them can be really valuable. And then one of the last sections I'll talk about is one tool that you can use to shift your focus and to bring your attention onto the positive, onto the cheese. And that's this concept of mindfulness. So this is, mindful versus mindful. So mindfulness is a process, is a psychological process of bringing someone's attention to the present moment without judgment. That's a really, really simplistic way of thinking about mindfulness. There are lots of really useful resources for mindfulness. A really popular program is called MBSR, which is available in various places, and I think even online, which is a very standardized course called Mindfulness-Based Stress Reduction. There's some really excellent apps now. Headspace and 10% Happier are some really popular ones. And then a handful of books I'll list here that can be really useful for learning about mindfulness and gaining the skills of mindfulness. We did a little research about mindfulness interventions in patients with Parkinson's disease. So this was specifically in a cohort of patients who were recently diagnosed with Parkinson's and then went through a 6-week mindfulness training program. I did this with a wonderful neurology resident, Zima Shaji, who's there in the upper corner. And what we found in our research is that patients did learn to be more mindful. So that was depicted here in this mindfulness scale, day-to-day experiences. So after the blue bar is before the course, the red bar is immediately after, and then the green bar is 3 months after the course. So people actually continued well after the course to become more and more mindful as they practiced the skills that they had learned. And on this bar, this shows the perceived stress scale. So how much were people bothered by their symptoms? And after the course, it went down by 14%. And 3 months after the course, it went down even further to 22%. So patients' symptoms didn't actually change. They had just as much stiffness and slowness as they had had before the course, but it bothered them less. So that's really important skill. And then these are just a few different sort of mindfulness tips. So if you don't have time to sort of go through a whole course, 6-week course, a few things that can be really helpful. I'll just focus on one of them, which is this concept of a self-compassion break. So this is taking even just a minute, but a few minutes ideally to yourself, where you just acknowledge the way that you're feeling, which can be as simple as saying to yourself, this is really hard. You can offer yourself self-kindness or self-mentoring. So if you were talking on the phone to a friend who is in the same situation, what advice would you give them? And then, as I said before, sort of similarly is celebrating every victory. So don't miss an opportunity to celebrate something positive. So as my last slide, I'd like to ask or give you the opportunity to take a minute and think about at least one of the things that I talked about today, if any of it sort of stood out to you as something that sounds appealing that you could do to improve your wellness today, and actually write it down. If you have a piece of paper available, or if you're on your computer, you could type it on a Word document or an email or a text or something. But try to choose something concrete that you feel like you can do today or put into action, today or tomorrow, to try to make steps towards improving your wellness. Let's give that a second. Okay. Great. Well, that's my talk, I think, just in time. I wanted to put up these websites that we had talked about before. So specifically our Care Wishes, the 5 Wishes, and the PA Pulse is that form that's usually printed in pink that we talked about before. And so I think we have some time for questions. Should have about 10 minutes. Thank you all so much.
Thank you so much, Dr. Lasker. Very, very informative, comprehensive, and inspiring. We have some questions that have come through the Q&A. So I will just start reading those to you, Dr. Lasker.
Great.
Okay. We were told once that, oops, let me start over. We were told that once on hospice, my husband would not be able to receive therapy such as physical therapy, OT, speech therapy, that really mattered to his well-being. Please comment on this.
Yeah, this is a really important issue. So it depends, apparently it depends on the particular hospice agency. So some are allowed to provide those sorts of resources like PT, OT, and speech, and others can't. This is actually one of the missions of neuropalliative care. So this sort of new concept of incorporating palliative care into neurologic diseases. One of the missions is to change things like that. So outside of the context of neurologic diseases like Parkinson's, getting PT might not matter that much, but in Parkinson's disease, it matters a lot. It can really have a dramatic impact on quality of life and symptom management. So in like the International Neuropalliative Care Society, for example, people who are engaged in advocacy through that group, this is one of the things we're trying to work on to change. So I agree with you. That's a problem. It's not the case for all hospice carriers, apparently.
Thank you. Also, the home health physical therapist discouraged palliative care, saying that it was expensive and complicated to put together. Can you please comment on this? Thank you.
Yeah. So it also well, there are a lot of misconceptions about it. So this may have been a reflection of that. Palliative care can come in different forms. So in part, it's this sort of concept of thinking about care in a broader way and improving quality of life. There is specialty palliative care, which is a area of medicine. So there are palliative care doctors. So you can seek out a palliative care specialist. And that's just like visiting another doctor. So it's not particularly complicated or expensive. It's just a copay like any other. And then another form of palliative care is what's called primary palliative care. So that's your people like your primary care doctor or your neurologist that you already have, incorporating this into their care models. So it doesn't necessarily have to change the complexity at all. But is just starting to incorporate these ideas into your care. So that's something you can ask your neurologist that you already have to have these types of conversations.
Thank you. In regards to healthcare planning, etc., people often choose no to antibiotics because they are not life-saving, but they can be a comfort measure. Your comments?
Yeah, yeah, I think that that's very true. So if someone has an infection that's causing discomfort, then it makes sense to treat that to relieve the discomfort. So I think, that's where having sort of detailed conversations with your healthcare proxy can be really valuable, so that they know how you would feel about that in the setting. It's a great point.
Thank you. Sometimes support groups are not for everyone. Could palliative care be considered a one-on-one support group? Yeah,
that's an interesting question. When we were doing this, the mindfulness project that we were doing before, one really interesting thing that came out of it was that the patients who are part of the group started to feel like the course was becoming a support group for them that wasn't talking about talking about Parkinson's disease specifically, but was sort of talking about wellness in general. And some of the people in that group did not like being part of regular support groups, but really enjoyed this other context. So I think it can be seen in that way. And I think, talking with a palliative care specialist or a chaplain who may be part of a palliative care team can have similar benefits to a support group, sort of talking with peers.
Thank you. And this is just a comment that people ought to consider palliative care at the beginning, so the care team can get to know the family and recipients rather than a time of random crisis.
Yes, great point. Yes, I think not only is there so much palliative care can offer throughout the disease, including right at the beginning, but it is good to know, if you were going to go to a palliative specialist, if you had access to one, getting to know them early on could be really useful so that they already know your values rather than waiting until there's a crisis of some sort to meet them.
Thank you. And what is the best way to find palliative care in your area?
Yeah, so probably talking with either your neurologist or your primary care doctor would be the best way to do it. So a lot of healthcare systems, you can just put in a referral to palliative care, and that would allow you to meet with a palliative care specialist. Not all palliative care specialists are knowledgeable about neurologic diseases. So I would also say that if there's a specific aspect of this that sounds appealing to you, you could always bring that up with your neurologist or your primary care doctor to see if it could be incorporated in a primary palliative care model. Those are the two main. Yeah.
Thank you. And this is in conjunction or similar. Can all palliative care does it come through a hospice or it
would be, yeah, I guess not. It is. So
okay.
Hospice is sort of a very specific service that's paid for through Medicare or Medicaid in a very specific way.
Okay.
And palliative care services would be separate, that are just paid for through normal insurance.
Okay, thanks for clarifying. And there are so many hospice services out there, it can get overwhelming. Is there any type of website or organization or place that you can go to kind of see the similarities and differences?
That's a good question. It's going to be very particular to your area. So I think, if you have one way to address that would be to meet with a social worker, for example, who's affiliated with your neurologist or primary care doctor, or patient advocacy groups like this one, where you could meet with people who are knowledgeable about Parkinson's disease and may already know the answer to that. So it can sort of point you in the direction for your area.
Okay, thank you. And this is a comment. I wish all of this information had been available to caregivers from the start, and we wouldn't have to do our own searching when already on call 24/7. It was very difficult.
Yeah, that is part of the goal of this new, of this movement of neuropalliative care. And a lot of the Parkinson's advocacy groups like the Parkinson's Foundation and Davis Phinney Foundation are starting to make a lot of materials about caregiver support and these other aspects of Parkinson's disease care. So I think we're getting better at it. So hopefully that won't be the experience of everyone in the future.
Thank you. And I have one last question. In speaking to your research on mindfulness meditation in Parkinson's while you were at St. Luke's University, what are some of the benefits that you would highlight to a person with Parkinson's who may be wanting to try meditation? And where would you tell someone possibly to start?
Yeah, so I think the thing that came out of the data specifically was that reduced stress from symptoms. So sort of how much the symptoms were bothering them went down over time. So that was sort of the big picture piece. A lot of just in sort of individual conversations with participants, one thing that came up was the power of attention, sort of learning to strengthen the muscle of attention came in really handy in different situations. So one that was really memorable to me was a patient that talked about how it impacted their walking up and down stairs, which had always been difficult for them. And now they were bringing sort of their full attention to the task of walking up and down the stairs and found that it was much safer. They found it a lot easier. They didn't tend to get distracted. So there are these moments in the day when having the ability to really focus your attention in on the task at hand can be really useful.
Well, thank you. Thank you again for your wonderful presentation, and we'll see you after Dr. Cole's presentation.
Great.
And everyone, we will now be taking a 5-minute break. So please come back at 12:07 and we will see you then. Get up and stretch a little bit and do what you need to do. Thanks for being here.